Hey there, and happy Friday. I'm so glad it's Friday, and I'm excited to talk to you today about the topic of functional neurologic disorders, my favorite, and the role of neuroplasticity. But most importantly, I got tons of questions from you all about FND, and I'm going to answer them tonight. And if you put them in the chat here, I will also answer them. I am going to try to go through one by one. We had a great session earlier this week answering your questions, and I just had so much fun. So thank you for that. By the way, if we haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist. I am the owner, founder of Re+active Therapy and Wellness. Hello from Portugal. Awesome. I'm so glad you're here. I'm also a mom. I'm wearing my South High School volleyball gear today. I just came from my daughter's game, and I love chatting with you all about these topics. So the overall theme today is functional neurologic disorders. The overall theme is on neuroplasticity. So I want to give one piece of background because people did say they wanted to hear about the topic of the predictive brain. And if you've joined me before, you know I absolutely love this article. It's Hallett and colleagues 2022, and I absolutely love this diagram. And this diagram is not about neuroplasticity, but the potential mechanisms in FND. And what that leads us to as clinicians is how we can, by understanding the pathophysiology, how we can kind of really work backwards and harness the brain's ability, not just the brain, by the way, the brain, the whole nervous system's ability to change. And we do this through therapy. So very briefly, this diagram demonstrates the predictive and feedback mechanisms in a simplified way, by the way, because all of this is so complex when it comes down to the nervous system, but how movement is generated. So in general terms, if you go on the left-hand side, you have intention, you have movement planning, you have movement generation, and then the movement happens. And then as you see, it's a loop, right? So you get this multimodal integration that's down at the bottom there. And then you also get feedback from interoception inside of the body and exteroception outside of the body. This feedback gives feedback to the model in the brain that normally would predict. Well, normally it does. That's what the brain does. It is constantly predicting and trying to be efficient for us. So the brain predicts, it creates a model and kind of takes us back through the loop. So when we look at a functional neurologic disorder, I think in many ways, I always think this, it makes sense that functional neurologic disorders exist because of how the brain works as a predictive, really like machine. And we look at two components of what might affect and what might contribute. Remember on Wednesday, if you joined us, I talked a lot about not chasing symptoms in FND, and you could chase the movement problem and miss all of these pieces that might be contributing to it. So on one hand, and I actually like to start at this like bottom up, maybe somebody is not giving prediction errors. Maybe they're not getting good interoceptive or exteroceptive feedback, and therefore the prediction error is incorrect, and therefore the model of movement continues and they have tremor, or they have weakness, or they have dystonia. So we need to test that out. We better be testing the sensory systems, interoception and exteroception. We better be testing how those are integrated, like in the cerebellum, with attention and sense of self-agency. And then we do need to look at the ways these things are modulated, either from the attention to the act, the emotion and how that affects those pieces, how attention affects those pieces. We want to look at all of those, not only through assessment, but then we can bring that right into treatment, because if it got wired inaccurately and therefore a loud sound causes a tremor, which is not how it happened in birth, right? We can, because of neuroplasticity, and many times I think of some of the symptoms that we see are kind of neuroplasticity gone awry. Well, if that has happened, then the reverse can be true. We can help somebody get more accurate interoceptive or exteroceptive feedback. We can help with the integration part. We can help in the intention, planning, generation. We can help if there's an emotional regulation piece, an attentional piece. That is exactly where we can intervene. And aren't we lucky? I feel like we are like the luckiest profession in the world as clinicians, as PTs, as OTs, as speech therapists, as psychologists that get to work with people with neurologic disorders and help reprogram things like this. It's so, I feel so lucky. So this is the predictive brain, and this leads us directly. So I'm going to pull up the pie chart again today. One of my favorite things is the pie chart, because you just don't want to leave home without it. It leads us directly into a treatment approach that is based on understanding the underlying pathophysiology, what is happening in the brain and those pieces that influence it, and really helping change the brain through neuroplasticity in many different ways. So what we talked about earlier this week is that it can't be as simple as just changing the sensory system or just changing autonomic or just changing motor control. That is why it's a pie chart. These pieces interact with each other. They and for each person, it's a different combination of pieces that we would look at from a treatment standpoint. So for example, from that last diagram, if somebody did have inaccurate interoception or exteroception, that would be in that sensory piece of the pie, and we would build those resources with that person. So that is kind of the basics of how we take from that pathophysiology and understanding the predictive brain into treatment. Now, I want to connect this to some of your questions. So I got lots of questions that that people submitted. So I'm going to try to go one by one. And again, if you have a question, I want to hear from you. You can put it here in the chat, and I'll make sure that I'm taking a peek here at it. So, and I'll remind you, by the way, if you're a clinician, next week, we're doing a free workshop all on FND. We're going to talk about the pie chart. We're going to talk about strategies. If you're a clinician, sign up at reactiveeducation.com. Okay, so one of the questions that came was, why does exercise and movement help? Why can that be helpful in functional neurologic disorders? So I'm going to leave the pie chart up here, because exercise and movement actually fits in a few different pieces of the pie, and this is why it can be so helpful. Number one, if there is autonomic dysfunction, exercise is actually one of the things that can help regulate the autonomic nervous system. But here's a catch. It doesn't mean like, let's all go run a marathon. If somebody has dysautonomia, and if somebody has POTS or postural orthostatic tachycardic syndrome, we actually have to move pretty slowly in that exercise progression. So what I've heard from some people is like, oh yeah, like I tried to exercise and it got worse. And yeah, you might have overloaded the system. And this is very, very true. You know, in the neuro rehab world, high intensity training is all the rage. And if somebody has dysautonomia, please don't go there. It is not, excuse me, it's not helpful. In fact, it's harmful. So this is where, as a clinician, you're going to make decisions based on the person in front of you. And if they have dysautonomia and POTS, high intensity training is not your thing. But exercise training absolutely is, and you want to test it. Somebody else asked, by the way, outcome measures. I use this quite a bit, but it's an exercise tolerance test. And I love the Buffalo concussion treadmill test. I use it for all populations actually, and it's really, really helpful to help understand a baseline heart rate and then to progress it very slowly. So I'm kind of answering two questions. Somebody else also asked about POTS and dysautonomia treatments. Those should be very precisely directed by an assessment of the autonomic nervous system, understanding a heart rate threshold for exercise, and very slowly and systematically progressing exercise through heart rate training. It can be done, and dysautonomia can be very well managed. Now, another piece, by the way, so this was Emily asked this question about POTS and dysautonomia treatment. Another big piece of this is through lifestyle interventions. So this is our occupational therapists. They are phenomenal, and really work on the components of lifestyle that directly interact with the autonomic nervous system. So you can actually see them like in our pie chart. The autonomic is right on top of lifestyle because those pieces of sleep, of stress management, of diet and routine and activity and pacing all directly influence the autonomic nervous system. So whenever I've met somebody with POTS or dysautonomia, absolutely, positively, they should be working with an occupational therapist that is skilled in lifestyle interventions. It can make all of the difference. If somebody, so I'm going to go back to the first question that somebody asked, why does exercise and movement help? In functional neurologic disorders, if somebody doesn't have dysautonomia, exercise and movement can really help regulate the nervous system, both from an autonomic standpoint, but even from a sensory standpoint. Something that I've been a huge proponent of more recently, and this is thanks to many of the great therapists in our Brain Bites groups, really like asking good questions and leading me down to think about these things and honestly mentoring me about these things. But that is weight training and incorporating that as part of exercise and movement routine, because the weighting really is a sensory training too. And you know what? I am all for like, let's do two things at once. let's train the autonomic nervous system. Let's train the sensory system. Heck, we're training physical limitations. If strength is an issue, we're training motor control. Let's do all of those things together. I think again, I'm going to go back to the autonomic treatment question that somebody asked. I think where I see things go awry is when people have been given kind of a traditional exercise program. So maybe that was at a gym, maybe that was with a trainer, maybe it was a more kind of orthopedic style of physical therapy. And that I have found not to be as beneficial. And so when we think of exercise and movement, we want to include the principles of motor learning and motor control, like external focus of attention, in that exercise and movement. So I think really thinking about how you combine both of those things. Great questions. Okay, another question that somebody asked, and you know what, I'll try to kind of hit on the treatment questions first here. Sitting balance and then standing with a walker. So these are two really common things that we'll work on with people with functional neurologic disorders, especially if they have a balance component, maybe ataxia, maybe it's weakness. And a lot of times we're starting in sitting and moving into standing with support, standing with walkers, things like that. And the first thing that I want to tell you is, in the past, people kind of taught or suggested that you shouldn't use a lot of equipment in FND. And I think that's a little misunderstood. I don't agree. I think you can use equipment and it can be really beneficial in functional neurologic disorders. I think you just want to have a clear pathway to what that person needs and what that person wants for their mobility and for their independence. So in terms of this question was from Daisy. What are some things maybe that we would do for sitting balance? So Again, I'm going to bring us back up to that top of the pie chart in motor control. Whenever we're doing a functional activity, we want to make it very goal-oriented and externally focused. So if sitting balance is the piece, a lot of what we'll use are games. So balloons are a favorite of ours, ball games, tosses, things like that, but person specific. If you get that person that hates games or hates competition, this is not for them, right? So they might be doing an externally focused math activity, or and that might be more of a dual task. Maybe they're teaching you a lesson, right? So I've had teachers before, I have engineers, and I'm like, teach me about this. Put it up on the whiteboard. Give me a lesson about this. So those kinds of things could be really helpful for sitting, balance, and standing. Standing with a walker. Another piece that I think is really helpful is to take the focus away from the standing and from the walker. So one of the things I like to start with is even trying standing from a very high surface where you might be getting weight bearing through the legs, but you're not focused on that. I think when a person has a lot of attentional focus, like we showed in that predictive brain, it can really throw automatic movement out the door. So we want to unlock automatic movement for that person. We want to show their capabilities. We want to have them access their automatic movement capabilities. And so again, we would do that in a very person-specific, externally and goal-oriented focused way. So it might not be standing right away. It might be sitting high and weight bearing through the legs. It might be rocking and dancing and sitting, so you're getting some weight bearing if that's what the person loves. It might be games and balloons and hitting and competition and things like that. All of those things are really great for that activity. Okay. Love this one from a fellow OT who asked about Parkinsonian gait. Ooh, I love this question. No one's ever educated me on that with FND. Is it still low dopamine? What a great question. So functional Parkinsonism is a functional neurologic disorder that has the characteristics of Parkinson's disease, including slowed movements, so bradykinesia, akinesia, low amplitude movements, and a Parkinsonian gait might be small shuffling steps. Very common in a functional Parkinsonism. Absolutely. We've seen it. We've seen functional Parkinsonism. It is not associated with low dopamine, at least that we know that it is not, as far as we know. This has been studied, by the way. Functional movement disorders have been studied. There is some overlap with Parkinson's disease in that folks with Parkinson's disease may be more likely to have a functional movement disorders. It may also be that a functional movement disorder predates a Parkinson's diagnosis. Not for everybody, but there's been some studies that show that as well. But they're not in the same mechanism as far as changes in the dopamine producing cells in the basal ganglia. That is not found in functional Parkinsonism. However, what is found is a learned pattern of movement. And I got to tell you, this was such a good question. So thank you again for asking it. I used to do, at the University of Southern California, they had these neuroplasticity retreats. They were funded by a grant to bring together interdisciplinary researchers, physicians, healthcare professionals, from all over. And there were a lot of Parkinson's experts there. I loved this retreat. It was so fascinating. Lots of research shared, lots of great ideas. One of the components that one of the researchers shared, he was a Parkinson's researcher, he shared this idea of learned bradykinesia, learned slowness of movement. And what he shared was that in people with Parkinson's, they experience bradykinesia due to the changes in dopamine producing cells in the substantia nigra, the part of the basal ganglia. And they also learn to be bradykinetic, because that is what our brain does. It experiences a pattern, it predicts it, and it reproduces it. Now, this doesn't mean that Parkinson's is a functional neurologic disorder, but it does mean that some of the patterns that can develop are learned patterns. What this means for us as therapists is that while Parkinson's is a neurodegenerative disorder, we can help drive the opposite learning. Anti-bradykinesia is what I would call it. So that's a little side note, but I think one of the things I think about with this predictive brain model, it makes sense to me that in Parkinson's, you might learn to move a particular way because your brain predicts it and you're not getting accurate sensory feedback due to the diagnosis. It makes sense to me that I have met and experienced a few people with cerebral palsy who also develop functional neurologic disorders because they've experienced a particular pattern of movement as well. And they might also have a sensory feedback issue that develops a learned pattern ingrained that's not actually the cerebral palsy. Same happens in stroke, and people develop compensations that are not helpful. This happens in neurologic disorders across the board. It happens in concussion. It happens in brain injury. It shouldn't be surprising that it happens. This is how our brain works. And folks should be in rehab because that is exactly what we look at. We test out these pieces and we can help break those patterns and help a person relearn their movement. Great question. Okay, I've got another question from Rebecca. Thank you, Rebecca, for this great question. How do you get a patient to really get into non-traditional activities, is what she called it, but like fun activities? First, let's make fun like traditional. Let's make that the thing. That's what I would say. But I get what you're saying, because if a person has in their mind, I'm going to go to physical therapy and I'm going to do exercises, and that's going to include my kettlebell. I'm going to have a band around my hips, and I want to do exercise. And you're coming in and like, let's hit the balloon and I want you to blow these bubbles and we're going to dance to the music. And they're like, heck no, that is not therapy. That's not what I want to do. How do you match those things up? Now for me, and we teach this, we're going to talk about this in our workshop next week. The number one thing is the person in front of you. What is important to them? How do they understand their diagnosis? How do they understand therapy and what's going to help them get better? And then you can meet them. What do you understand about the diagnosis? What do you know and understand? And we talk a lot about creative activities and fun and goal orientation. And I talk about those things with patients. Like, why is it important to have an external focus? Why is it important to be goal-oriented in a movement pattern? What does that do in the brain? And I'm going to be honest, I really only bring that up if the person is interested. I'm never the one to just kind of like, well, here, let me just vomit everything I know about FND. I care more about what the person with FND cares about first than I care about like my own knowledge. So to that point, might there be a person that so strongly believes that it will be repetition and exercise that help them? We might find a common ground of repetition and exercise that helps them. I'm thinking very specifically about a kiddo that we worked with who was brilliant and didn't like to play at all. And that really changed what we did in therapy, and we brought in those things that he was most interested in. Now, I would also say one of the things that has been so helpful in this realm of external focus and things like that is really getting deep in with the person of what is most important and salient to them. And often I don't find it that first day, maybe even that first week. My experience with a lot of folks with a lot of neurologic disorders or chronic diseases is that it takes a little while to build trust with a person in healthcare. Many folks that I have worked with have had a lot of medical trauma. They haven't been believed or understood. And so then they're coming in and working with us, and we need to build up a trust. And so what I will say is be patient then. Build that trust, really get to know that person, and see if you can find some inroads to play. And I'm going to say, maybe there are some people that I haven't had a super creative, fun, playful session with that just wasn't their personality, but we found a way to engage them and their brain to help with automatic movements in other ways. I also think it's been really helpful to have a team. So psychology, OT, PT, we do co-treats, we do sessions together, and they've been really helpful for helping us uncover some of those things for a person, or maybe the barriers for the person. Okay, I got 2 more questions that people submitted here. One was functional tics. What about functional tics? And I'm going to put it in kind of our treatment pie chart here. Functional tics are a type of functional neurologic disorder, in fact, a functional movement disorder, that are different than Tourette's syndrome. So they are most often, by the way, diagnosed much later in age, not in the early age, like Tourette's syndrome, and they are very treatable. We see a lot of people with functional tics, and they do really well. And when it comes down to the pie chart, again, really good assessment here, but you want to look at what are the underlying pieces of the functional tics. Some of the biggest pieces that we see are sensory, autonomic, and psychosocial. And I include psychosocial in here because as we've seen functional tics in some teens, maybe young adults. Some of this was happening around bullying at school, or other really like stressful or traumatic events occurring. And those psychosocial pieces actually directly influence the sensory and autonomic. Now, I'm not saying that is for everybody with functional tics, but that's been some of our experience. And some sensory dysregulation and autonomic dysregulation contributing to the tics. And so, therefore, treatment in those realms. Absolutely. Okay. Then finally, and by the way, if you've got questions, you can go ahead and put them here in the chat, but I'm actually responding to all of your questions that you sent me. So thank you so much. The last question I have here was, what outcomes do you use for patients with functional neurologic disorders? Great question, because we have a few that we love and that we use all of the time. And also when people come in for our functional neurologic disorders program, before they come, they get sent quite a few outcome measures. So the number one that we use is the PSFS. That's the patient-specific functional scale. And I love it, just even in the name, it's specific to the patient. It asks the patient to identify their activities right now and rate them. So walking, I'm a 0, I'm in a wheelchair. Going to Dodger Stadium, I'm a 1, I really can't handle it, and so on. So they rate it 1 out of 10. And we added on an avoidance scale on that. How much are you avoiding this activity? So we love that scale. We also do some other screening outcomes. So we use the Compass 31 for the autonomic nervous system. We use the sensory profile, either the one for kids or adolescents and adults for the sensory system. We do some psychosocial screening. So we do the hospital anxiety and depression scale and the PHQ-9. In lifestyle, we do the perceived stress scale. We do the insomnia severity index, I think it's called, the ISI, as well, to get to some of the lifestyle pieces. I mentioned the Compass 31 as well. And then at the end of somebody's program, we have them do the patient global impression of change to rate how much change they have felt that they have had over their course of treatment. And that one's really powerful because we see that on a whole, people have a very, very high impression of change. And that's what we're looking to do as therapists, right? So those are some of the key reported outcomes. Now, we also do patient-specific measures. So if walking's a goal, we'll do a 10-meter walk or a 6-meter walk or a 6-minute walk. We might do some test of aerobic function and endurance as well. So we do a stepping test, we do the buffalo test. We might do a 5 times sit to stand. We might do a timed up and go. We might do a mini best test to look at balance. And again, these are very person specific. We'll look at a person's upper extremity function and we'll do a box and blocks, or we'll do the 9-hole peg test, for example. So again, based on really what that person needs and what's specific to them. So great question. I see some more questions here. Does low heart rate variability and extreme increase in symptoms with exercise physical activity indicate dysautonomia, or can the increase in symptoms occur without dysautonomia? Great question. Well, number one is I don't diagnose people. So I'm a physical therapist, but I screen these things, and I screen heart rate variability. I also screen resting heart rate. We also do an active stand test to look for the presence of POTS, postural orthostatic tachycardic syndrome. And we do an exercise test and look at a person's exercise tolerance. And what we're really screening for is there's some sort of autonomic dysregulation. And again, I don't diagnose POTS, but I can screen for it and then send somebody to a medical doctor for that actual diagnosis. And even while they're waiting for the actual diagnosis, we're going to treat it. Because what we're looking at are symptoms. Physical therapists are trained to test these symptoms and treat them. So we can test symptoms of dysautonomia and treat them. So particularly low heart rate variability, we love using the Leaf. It's a portable EKG that measures heart rate variability much more accurately than my Apple Watch or the Whoop or some of those other ones. The Polar Heart Rate Monitor, also really helpful for that. And we'll look at heart rate variability, and we'll look to see, for example, does that precede a functional seizure? We'll look to see if that drops with particular activities or if it goes up with particular activities. And that gives us a good sign of, if we're kind of testing out what autonomic training is really helpful, we can use heart rate variability as a measure of that. So really, really great question. So I didn't finish it all the way. Could the symptoms indicate something? Could they occur without dysautonomia? So this is why we got to look at the whole picture and the whole pie, because can you get symptoms with exercise due to visual motion hypersensitivity? Yeah. To vestibular dysfunction? Yes. To sensory dysfunction? Yes. And it might not be dysautonomia. So that's why we need to test those out. So we might use a heart rate monitor, and if we see a direct correlation, that's pretty indicative. But if we don't, or we see really, really high level of symptoms, we might actually be looking at other systems. And I'm going to look like the visual system, vestibular system, proprioceptive system, hearing, all of that sensory integration. Those are big culprits too, that can limit somebody's exercise tolerance. What a brilliant question. What a brilliant question that all of these folks really shared with me in the last few days. I'm so thankful. I'm going to pull up one more picture here as I get ready to sign off, and I'll see if I can find it. I feel like sometimes I'm scrolling through so many things and it doesn't pop up because I use my phone and my camera a lot during the day. And here it is. I wanted to remind you, if you're a clinician, we are doing a workshop next week on functional neurologic disorders. It's live and we're offering it on 2 days, either September 19th or September 21st. That's next Tuesday and Thursday. Brittany, Kim, and I are doing this together. We started putting it together over the last few weeks, which is why I've been diving into all things FND, and it's awesome. I gotta tell you, it's really awesome. We are bringing in the experience from our entire team to this workshop. And if you are a clinician looking to really transform your practice, this is going to be a game changer for you. So come sign up. It's at reactiveeducation.com. Join us live, catch the recording, and we'd love to see you there. In the meantime, if you have questions about FND or many other things, you know where to find me. I'd love to hear from you. And I love your questions. It actually, I learn a lot from it. So thank you so much for being here, for joining me on a Friday night too, and have a wonderful weekend. Good night.